Good morning, everybody. I hope that you are all safe at your homes. Please do take care of yourself and your family. So now moving on to the next topic in the gastrointestinal tract, very important topic, and that is carcinoma of colon. We will just change the sequence. Before I'll first cover the carcinoma of colon, and if time permits, then we will go on to discuss the different kinds of polyps that are present in the colon. So to start with, this is a very ideal scenario that comes to your operating with This is an ideal scenario where you get a 65-year-old male who comes to your OPD with complaints of progressive generalized weakness for the last 6 months. When you examine this old man, you get pallor, there will be Colonic. So you already started your clinical postings, you must be aware what is Colonic, spoon-shaped nails, and he has a smooth and bald tongue. On his hematological examination, you get a hemoglobin of 6 grams per deciliter, a mean corpuscular volume of 67 femtoliters, MCH 20 picograms, RDW of 19, total count is normal 7000, differential count is normal, platelet count is also normal. So from the hematological values, we can say that he is having anemia, as his hemoglobin is 6 grams, and he is having a microcytic anemia, evident by the MCV values. So why an old man should have anemia and generalized weakness for the past 6 months? So then you investigate further, you suspect some bleeding, and you ask for the history of piles or hemorrhoids, you ask for history of peptic ulcer, you ask for history of passing blood through urine, that is hematuria. The stool examination is negative for the parasites and ova. But very surprisingly, and that is a very common scenario, the stool examination for presence of blood, that is we call it a stool for focal blood, is positive. So then we move on to the next step immediately. So we suspect that there is some pathology in the colonic part, and you do a colonoscopy and you get a very large mass in the cecum, and then the diagnosis becomes very clear that it is carcinoma of colon. Please remember here, this is exactly the same way most of the patients of CA colon come to us. So there is a dictum in medicine. So if it is a man more than 65 years of age and he is having iron deficiency anemia, so unless proved otherwise, it should be taken as malignancy. So you should have a very high suspicion of malignancy in all the patients who are above 65 years of age and who are having an anemia, especially iron deficiency anemia. Now when we start with this topic of carcinoma of colon, you will come across these terms like loss of heterozygosity, constipation and obstipation. Again, I thank Dr. C.S.B.R. Prasad as I taken this presentation from internet, and I will explain on this presentation. So the commonest histological type of tumor that you get in the colon is an adenocarcinoma. It is said that God or whatever you believe, nature has made it so simple for us that the very long tubing of small intestine, they harbor a very less of pathology, so that it is reachable for the doctors. So it is said that small intestine is a very uncommon site for neoplasms. Only thing that can occur there may be very rarely in carcinoma, carcinoid, lymphoma and sarcoma. Whereas when we talk of large intestine, colon and rectum, it is a very common site for adenocarcinoma. So as already discussed or told, colorectal carcinomas are most of the times they are adenocarcinomas. The age group is very classical to remember. It is in the age group of 60 to 70 years. Please remember this. This thing you have to be highlighted. The age group of occurrence of carcinoma of colon is 60 to 70 years of age. Very less percentage, that is, it is said that only less than 20% of the cases occur before the age of 50 years. Males are more commonly affected than females, and most of these colonic carcinomas, they have got a very classical, we can say, a geographical distribution, in that they are most of the common in the developed countries. It is said that they are almost 30 times less common in countries like ours and Africa. Very important risk factors for colonic carcinoma are a diet which is very low in fiber, diet which is very rich in fat and refined carbohydrates, and diet deficient in different vitamins, especially vitamin A, vitamin C and vitamin E. So what happens basically is a very high diet, very rich in fat and carbohydrates, enhances the hepatic synthesis of cholesterol. So you are all aware, first year biochemistry, that this fat will be metabolized in the liver, and there will be excessive production of cholesterol and bile acids, and which later on are converted into carcinogens by the intestinal bacteria. So that is the basic link, how diet is linked with the colorectal carcinoma. So nicely shown again in this picture. Same thing, a very high fat intake will lead to increased synthesis of cholesterol and bile acids. So bacteria act on these chemicals and they produce carcinogens. Add on to this the consumption of low fiber, low residue. Because of this low consumption of low fiber, the stools, the remain or the undigested part remains very long in the intestine. They take very long to clear, and because of this prolonged staying of that material, they get into contact with the mucosa of the colon, and it is said that these chemicals then later on will cause gradually the malignant transformation leading to colorectal carcinoma. So this is one of the pathogenesis of how a food or a diet can lead to colorectal carcinoma. Please remember, there are different things that happen when we talk of colorectal carcinoma. So one of the risk factor which is a high diet which is rich in fat and carbohydrate, how it leads to carcinoma of colon. So if these risk factors are avoided, so if you start the diet good in fiber, good in vegetables, so then the dietary modification can lead to colorectal carcinoma incidence to decrease, as well as some drugs like aspirin are also said to be important in the pharmacological chemo prevention. So one has to have a low fat and a high fiber diet, and it is said that aspirin or other NSAIDs, they have a protective effect by, as you all know, again, aspirin inhibits COX-2, which decreases the prostaglandin E2, which decreases the epithelial proliferation. So they also, so this is called as a pharmacological chemo prevention. and diet. So one should remember these two are important when we discuss the carcinoma of colon. Now coming to the most important factors, that is genetic abnormalities, and there are heterogeneous genetic abnormalities and epigenetic and genetic abnormalities when we talk of. So this colon cancer in short has a very high relation with genetic problems. So what are the two distinct pathways for development of carcinoma of colon? And the first important pathway, it is said to be APC beta catenin pathway. This is associated with the classic adenoma carcinoma sequence, and another is the microsatellite instability pathway. So first we will see what is APC beta catenin pathway. No need to be going into the depth as undergraduate students, but you should be aware that these are the genetic things that happen, or genetic abnormalities that cause carcinoma of colon. So this is a signaling pathway which controls the cell fat adhesions and cell polarity during the embryonic development. So this APC gene, which is located at the 5q21, it downregulates the growth promoting signals, and it is said to be a tumor suppressor gene. So this APC gene is a tumor suppressor gene. And then important function of this APC protein is also to downregulate the formation of beta catenin. So what happens here? This is again a diagram from your Robbins. So this WNT signals through a family of cell surface receptors called as frizzled, just to show you that how the cell proliferate, how it receives the signals, how they are attached to the receptors. Once they are attached to the receptors, how the intracellular signals are given to the nucleus and how the nucleus acts. So most of the times this adenoma carcinoma sequence, I told you, it is very important part. So 80% of these tumors are sporadic colon tumors associated with this mutation of the APC gene or loss of heterozygosity. Now it is not sufficient. You have to have additional mutations for this to occur in the form of activation of mutation in the KRAS, mutations into SMAD2 and SMAD4, P53 mutations, methylation of the promoter region, and increased expression of telomerase. Very important things to remember, and very important diagram now to remember is that. So you can see that there is a normal colonic mucosa, submucosa muscularis propria. A person has a germline inherited or somatic mutation of cancer suppressor gene, that is said to be the first hit. So he has an APC at 5q21, and which is now, that is the first hit. Now what happens is that there are methylation abnormalities that are taking place, and then in this there is an activation of normal alleles. Now this is said to be the second hit. Now once this mucosa now becomes at risk for development of an adenoma and later on development of carcinoma. So after this second hit, there may happen that there are proto-oncogene mutations, for example KRAS, and then there is loss of additional cancer suppressor genes and overexpression of COX2, P53, which is located at 17p13. There is loss of heterozygosity at 18q21, and then this adenoma will develop into a carcinoma. So this is how most of the times the development of carcinoma occurs. So person has a genetic problem, In short, he has hits by different kinds of mutations, loss of genes, overexpression of certain things, and this mucosa, normal mucosa, which was very susceptible by these genetic hits at different loci and loss of genes, gets converted into a carcinoma. The second pathogenesis when we talk of colonic cancer is an microsatellite instability. I will show you different presentations where we can see beautiful diagrams by which these things can occur. This is microsatellite instability, where there is a DNA mismatch repair deficiency. And what happens because of this deficiency, our body has a tendency to repair. If the genetic changes are mild, the body has capacity to repair. But then because of this problem in the repair, there is deficiency of this repair mechanism, then there is accumulation of mutations in the microsatellite repeats. Most of the times these mutations are silent, but if the mutations are resulting in the microsatellite instability, for example in the type 2 transforming growth factor beta receptor, which will lead to an uncontrolled cell growth, or in the microsatellite instability, which will involve the pro-apoptotic protein BAX, so where this lead to tendency of survival of these genetically abnormal clones, mutations in the BRAF oncogene, hypermethylation of MLH1. So in this microsatellite instability type of pathogenesis, the KRAS and P53 are not typically mutated, as we see in the case of the APC beta-catenin pathway. So this is another way by which microsatellite instability is also one of the factors which can lead to carcinoma of colon. So the combination of the following is very important for carcinogenesis. One has to have microsatellite instability, one has to have mutation in the BRAF, and methylation of specific targets such as MLH1. So this is the sequence when we talk about microsatellite instability. So a person has genetically acquired mutations of mismatch repair genes. There is alteration of this second allele by the loss of heterogeneity or mutation of the promoter methylation, converted into a microsatellite instability. And when there is accumulation of extra mutations in the genes that regulate the growth and differentiation, like TGF, BAX, BRAF, there is development of carcinoma. So APC beta-catenin pathway and microsatellite instability. In short, these two things are very important for you to remember when we talk of pathogenesis of carcinoma of colon. And there is third theory, that is hypermethylation of the promoter and absence of microsatellite instability. So in this, the increased CpG iodine methylation is very important in case of absence of microsatellite instability. And most of these tumors of this type, they harbor KRAS mutations, but P53 and BRF mutations are uncommon. So if we try to correlate these things with the morphology and the molecular alterations, we will find that when we talk of sessile serrated adenomas, there mostly the problem is of mismatch repair deficiency and microsatellite instability. And when we talk of tumors, adenocarcinoma proper, where mucinous differentiation and there is peritumoral lymphocytic infiltrate, Again, the most common pathogenesis is because of MSI, and this kind of tumors are frequently said to be located in the right colon. So that is why it is important for you to remember the molecular alterations, as they have a direct correlation with the morphology. So please remember, adenomas, the problem there is mismatch repair deficiency and microsatellite instability. And when we talk of right-sided colon cancers, mostly it is the microsatellite instability, and especially in cases of mucinous differentiation and peritumoral lymphocytic infiltrate. Now coming to the proper pathology part, that is morphology. How does a carcinoma of colon look like? As you all know, it can occur in any part of colon, but traditionally it is divided into proximal colon and distal colon. Why this differentiation? Or people talk of left-sided tumors and right-sided tumors. Now the thing to understand in this, because they have a certain characteristic presentation. For example, the tumors which are occurring in the proximal colon will be polypoid. They will come as exophytic masses, and very rarely they will cause obstructions, and the symptoms are very late. So the patients will come to you very late. They will not have, as they do not have obstruction, their symptoms occur very late, and when we see them grossly or through the colonoscopy, you will get polypoid and exophytic masses. When we talk of the distal colon or distal colon, you will get the lesions which are called as annular lesions. It is the lesions cause obstruction as they grow into the lumen and cause luminal narrowing. It is called as a napkin ring constriction. They cause obstruction, and the symptoms, they occur early, so they are noticed early in the course. So this is nice depiction of the tumors, you can see. So on the one side there is an exophytic growth, on the other side there is napkin ring type of constriction leading to obstruction, usually occurring in the transverse and left side of the colon. So just to show you how the napkin rings are seen. So nice picture showing you napkin ring type this thing. So another picture, colonoscopy picture. So one is an exophytic type of mass and another is a napkin ring type of presentation. So these napkin ring type presentations, they are noticed early, and when we talk of an exophytic type of masses, they usually come to notice later because they do not cause obstruction. So they can infiltrate into the muscle coat, and this is very important because it is one of the important prognostic factors when we talk of carcinoma of colon, and that important factor is depth of invasion. So if you study under microscope, very classically you get most of the tumors are composed of glands, and these glands are lined by tall columnar cells, and they will have all the features of malignancy, enlarged nucleus, hyperchromatic nucleus, pleomorphic cells, and there will be presence of abnormal mitosis. So glands which are showing features of malignancy. When the tumor infiltrates deep inside, it elicits a very classical desmoplastic response, meaning by there is fibrosis, lot of fibrosis there. The poorly differentiated tumors, they will form very few glands, and some of the tumors may produce very abundant mucin, and these abundant mucin producing tumors, they have got a poor prognosis. And in this also you will find one of the variety, some poorly differentiated tumors will be also composed of signet ring. So this again presence of signet rings, production of abundant mucins, they are all indicators of poor prognosis. So again a very nice histological section showing you a gland. You can see the columnar nature, and you can appreciate that all the nucleus are showing the features of malignancy. You can see hyperchromatic pleomorphic nucleus, you can appreciate the abnormal mitosis. So this is definitely a adenocarcinoma. So on this side you can appreciate this is a signet ring type of carcinoma where the nucleus is pushed towards the periphery and there is excessive accumulation of mucin. So proximal and distal is one of the terminologies. You can also talk of right-sided tumors and left-sided tumors. So when we talk of right-sided tumors of colon, they go undetected for very long periods, as you have seen, because of the exophytic nature. Usually the patients will come to you with fatigue and weakness due to bleeding of these tumors causing iron deficiency anemia. So we started with that slide of a 65-year-old coming with generalized weakness and iron deficiency anemia on the blood workup. So this is a classical presentation of a right-sided tumors. When we talk of the left-sided tumors, they will usually come to notice because of occult bleeding and very classical symptom again of change in the bowel habits, meaning by sometimes the patients will complain to you of constipation, sometimes they will complain to you of passing of excessive stool. So that is called as a change in the bowel habit. So there is constipation and there is obstipation. The opposite of constipation is obstipation. So passage of loose stools and frequency increases, and in constipation you don't pass the stools for quite a long time, or the patient will have the complaints of incomplete type of evacuation. So these are the clinical, even by the clinical features you can differentiate between the types of the tumors mostly, and you will have a cramping left lower type of quadrant discomfort. So this sentence you should always remember in medical. This is a very common clinical maxim. The underlying cause of iron deficiency anemia in an older man or a post-menopausal woman is GI cancer until proven otherwise. Please remember this very important maxim. So in old age persons, if there is iron deficiency anemia, so instead of considering nutritional deficiency as your first differential diagnosis, malignancy has to be your first diagnosis. So this is very important when we talk of clinical history, clinical examination. For example, iron deficiency anemia in children, the first differential diagnosis would be worms. Whereas the same iron deficiency anemia in a 65-year-old man or a post-menopausal woman, my first differential diagnosis will be GI cancer until proven otherwise. Very, very important thing to remember. So as the most important prognostic factors, I already told one of them, that is depth of invasion. So the moment the tumor goes into the muscularis propria, the chances of survival become less. And second most important is prognostic factor is lymph node metastasis. The commonest site where this colon go is the bones, lungs and liver. So the metastasis may involve the regional lymph nodes, lungs and bones. But when we talk of colon cancer, liver is the most common site of metastatic lesion. So when this is very important to again point to remember, where the mets in the liver are mostly umbilicated. So this is a nice diagram gross picture to show you, that is umbilication. So you'll find discrete nodes in the metastatic deposits in the liver, and if you take section from them, which is shown exactly in the lower slide, and you will get a nice mucinous adenocarcinoma. So this is a metastatic colorectal carcinoma into the liver, metastatic liver. So there is AGCT classification of colorectal carcinoma, where tumor, they have classified into tumor invading the submucosa, tumor invades. So T1 classification nodes, and this is the usual TNM classification which you should be aware. So this is another diagram showing you the same but diagrammatically represented AGCC colorectal carcinoma staging and survival. So if you see that the stage 1 and 2, the survival is excellent, but when it comes to stage 3 and stage 4, the survival is very poor. So that is very important for you to remember. So that was about carcinoma of colon, a very famous saying by Burkitt as regarding the fiber and colonic carcinomas. So he says that America is a constipated nation, and if you pass small stools, you have to have large hospitals. Okay, so I'll try to show you one more presentation on the same topic so that it becomes easier for you to understand. Again, this is taken from the net from my Professor Khalid, but this is nice basic concept, so I thought that we will just rush through this presentation. So when we talk of by definition we talk of a colon, so it starts from the cecum to anal orifice, and very nicely shown in this diagram. The total length of colon is 150 centimeters in length. Dentate line at the anal, at the start of anal sphincter. So this is the start, or we can say end of the colon, and there are fixed you can say flexures. One is a bend, flexure or bend at the hepatic region, and one is bend at the splenic portion. So we just remember this from this diagram. Then there are different types of reflections: peritoneum, investing fascia of rectum, presacral fascia. So when we talk of staging and when we talk of the treatment, the involvement of this becomes, they get an important. Blood supply of the colon, most of the times it is done by the mesenteric arteries, superior mesenteric artery and inferior mesenteric artery. This is a nice diagram to show you the blood supply. Very important thing to remember, the lymphatic drainage. You have a lot of epicolic nodes, paracolic nodes and principal nodes around the vena cavas. So the lymphatics can be upper third, middle third and lower third. So this is the famous adenocarcinoma sequence. We have just discussed that. Normal epithelium, there is APC gene which leads to an hyperproliferative epithelium, dysplasia, because of the alterations in the DNA methylations that occurs in the adenoma. So this is an adenocarcinoma sequence. there is problem with the KRAS, leads to this intermediate adenoma. Then again there is conversion by this P53 gene and causes malignancies, and there is a metastasis. So when we talk of incidence, this is said to be the very important statement to remember. It is the second most common cause of malignant deaths in America. Second most common cause of malignant deaths in America is number one common GI tumor, and it is also third most common cause of deaths when we talk of overall deaths. So these types we have discussed, three common varieties: colorectal carcinomas, hereditary, familial, and sporadic. So when we say it is an hereditary, we have already seen the person will have a family history. Usually the tumors will have at a young age of onset. He will have multiple defects, autosomal dominant in nature, and there will be tumor markers by which you can identify this. So that is that variety is hereditary. In hereditary also, one will have this adenoma, different types of hundreds to thousand polyps in a teenage male. That is because of APC gene. There is early progression in 1 to 5 years, and this unfortunate teens, they have got 100% risk of developing of carcinoma colon. So early screening and prophylactic surgery is the only treatment. And when we talk of hereditary non-polyposis colorectal cancer, so very few rectal polyps, right-sided polyps, they develop 1 to 2, 3 mismatch repair genes, and these hereditary non-polyposis colorectal cancer, these polyps will have, persons with these will have 70 to 80% lifetime risk of development again cancer. So early screening and prophylactic surgery is very important in cases of this. And then when we talk of familial and sporadic type, so person is born with mutation in all cells of the affected individual, genetic polymorphism, modifiers, defects in the tyrosine kinase, all have been implicated. So, and then when we talk of a sporadic type, you don't have a history of family history. Older populations, this is the classical presentation, presents as an isolated colon or rectal polyp region, and in these persons the genetic mutations are limited to the tumor itself. So this is the three type. The patients will come to you with anemia, loss of weight, and non-specific abdominal symptoms. When we talk of the right colon and left colon, I have already told you there is mass in the right iliac fossa, weight loss, anemia. And when we talk of left colon, obstruction, spurious diarrhea, constipation alternating with diarrhea, that is change in the bowel habits, abdominal distension, mucus discharge per rectum, perforation, and peritonitis. If the tumor is in the rectum, patient will complain to you of tenesmus, pain, bleeding PR, and constipation. And when we talk of metastasis, patients will have ascites, malignant diffusion, jaundice, and bone and brain metastasis. So the very classical, the right-sided one versus the left-sided one, cauliflower polypodal type of variety. Occult blood will be there, mass in the right iliac fossa, weight loss, anemia, intussusception, and most of the times they come late. So right-sided colonic tumors come late as against the left-sided colonic tumor, which is the constricting variety, comes to you with alteration of bowel habits, bleeding per rectum, and then this can be detected early because of the obstruction, of features of obstruction. Workup, you do a colonoscopy high risk, low risk, rectal and metastasis. So you have the fecal occult blood testing, you do a sigmoidoscopy, proctoscopy. So by inserting this into the colon, you can diagnose this. So it is a dictum in America that anyone has to be screened above the age of 50, or if a person is in the high risk group, every 10 years he has to get his colonoscopy or sigmoidoscopy done. So proctosigmoidoscopy is one of the easiest modality where 50% of polyps and the left-sided masses are detected, which can be done on an outpatient basis. Reliable, you can take a biopsy while doing the procedure itself. If you see a polyp, you can take out the polyps, but you have to examine the colon till the cecum, usually done under sedation. And radiology, if you do a contrast, the classical sign you can see there. Called as apple core appearance. So these are the different modalities. Again, radiology helps, sonography helps, and colonoscopy and sigmoidoscopy are the modalities you can do for the workup. When it comes to lower rectal mass, you can do a proctoscopy, you can do a biopsy, you can do a MRI, CT scan or PET scan. You can do an USG abdomen and have a look at the patient's general condition as well. So with this, we finish the important topic of carcinoma of colon. For you, important to remember is that genetics play a very important role in causation of carcinoma of colon. Number one, diet also has a very important role in causation of colon, and the presentation of colonic cancer differs. Right-sided, they come in a different presentation. The left-sided ones, they present differently. Histologically, most of them are adenocarcinomas. So with this, we stop with this today's lecture on carcinoma of colon. Thank you. Well,